Been discussing this afternoon the bid by private health insurers to lift their premiums by as much as 7% this year from April. In fact, the Prime Minister, as we saw earlier, is not indicating the government will stand in the way. Joining me now is Michael Armitage, the CEO of Private Healthcare Australia, the industry's peak body. Thank you for your time this afternoon. Can I start by asking, why do private health funds want this sort of increase?
Well, first let me say we're not sure that is the increase. That's only speculated at the moment, and I don't know what that increase is. But what we do know is that the independent regulator that looks at all the figures on both sides of what the premiums cost and what they pay out said that last year the benefits that funds paid on behalf of their members went up by 9.1%. So most Australians realise that if the benefits that are being paid out on their behalf has gone up by 9.1%, there has to be an increase in contributions to cover that increase. The dilemma is that we all realise, certainly we do in the industry, that no one likes having a premium increase. That's not popular. But sadly, we have no control over the costs that we're asked to fund. We want to talk with the government about getting some measure of control and potentially being able to keep people in the lower technological area, like the primary area, which will lead them to have better outcomes and will be less expensive, because at the moment we're not allowed to pay for that care.
Well, I want to explore some of that, but this 9% increase in benefits being paid out is a stark figure. What's driven that largely over the last year? Because it does sound like a big jump.
It is a big jump, and we're as horrified by it as everybody. But the independent regulator said that the amount of benefits that we paid in hospitals went up by 9.1%. The amount of benefits that we paid for prostheses, which is new hips, new knees, cataracts being taken out and new lenses put in and so on, went up by 10.6%. The amount that we paid for general treatment, which is dental and physio and those sort of things, went up by 9.6%. And these are all things that are generated within the system. Then we don't have any control over those. My personal view, having been involved for a long time in healthcare, is that a fee-for-service system tends to encourage more services. I mean, that's what the economists would tell you. We want to make sure, we want to try to see that we can bring to the government a proposal which would have maybe a fee for the right service or a fee for the best service.
So explain to me how that would work. How would that actually work?
Are allowed to do. Well, we all know that there are guidelines, for argument's sake, that are written by external bodies like the National Heart Foundation and the Cardiac Society and so on. We think that if doctors were to practice under those guidelines, there ought to be perhaps a benefit for that and less payment for those who don't. That's likely to lead to better health outcomes for people, which is great, at less cost. But even before they get into the specialists area, there are all sorts of things which everyone wants to be done when they need care. In the primary care area, that's making sure that their blood pressure is taken, making sure that they're on the right drugs, have they had the right investigations, are they doing their exercise programs and so on. The primary care system is something that we are not allowed to be engaged with. Often the first that we know that one of our members has, say, increased blood pressure is when we get a bill from the hospital for that patient to have gone into hospital to have, say, 4 or 5 stents put in and 3 days in intensive care at $100,000. It is stupid that we're not allowed to be engaged in their care beforehand, because it's better for them and it'll lead to a better financial output as well.
So what would you do if you did have that knowledge at the primary healthcare point about a patient's condition? What would the health fund actually be able to do?
Well, at the moment there are clearly things which benefit patients at a primary care level. Look, there are all sorts of programs from all around the world. There's a program put in by one of our compatriots in America, which is called the PHASE program. That stands for Preventing Heart Attacks and Strokes Every Day. And that's a program where the primary care doctors deal with patients who have got these potential illnesses. And the figures are something like 29% reduction in heart attacks, 30% reduction in strokes, 95% satisfaction by the consumers, 30% fewer deaths than a compatriot group of people who aren't on this program. We would love to put in a program like that, and everyone who is susceptible to those sort of illnesses would love us to do it. But legislation prevents us from doing that, and consequently we're faced with these 9.1% increases in outgoings, and we are required by law for the next 12 months to be capitally adequate, and that's why we need to keep on putting premiums up.
This, as you say, this whole area of allowing private health insurers to get involved in primary health care has been resisted politically under both sides for quite some time. Could it also, and is this what we're talking about here, allow the out-of-pocket costs for a visit to the GP, which can be $20, $30, $40, $50 or more in many cases, allow that to be covered by the private health fund? Would that attract a lot more people into the system?
Look, we're not sure that's the way it should go, but we actually have looked at some figures which would indicate that there is a potential for the primary care sector, which does the right thing, which keeps people out of hospital, to get dramatically more money than they're getting now, by which I mean 20 or 30% more money. Now that's a very, very significant increase, but in engineering that increase there would be a consequent decrease in the number of people going into the, shall we say, the expensive end of healthcare. And that's the end that people want to be in. They want to be in the primary care. If you ask people, would you like to be in, for argument's sake, that PHASE program that I mentioned before, or throw the dice and potentially end up in intensive care having stents put in, everyone would say they want the former. So that's where we think there ought to be money spent, and if you can save money in the hospital sector, you can hypothecate some of that, if you like, into the primary care sector, and it should be done. It would lead to better health outcomes and potentially dramatically lowered costs for the whole sector.
All right, let me finally ask you, if that doesn't happen, if the government's not looking at embracing any of these bolder reform ideas that you've been lobbying for quite some time, are there other ways that insurers can keep their costs down that they're not doing at the moment?
It's a bit of a furphy to say that their costs are high. The independent regulator puts out every year some figures which talk about the profit margin of insurers. And across the industry last year, the profit margin was about 4%. Most other years, it's between 1 and 3. Now, that is a minuscule percentage. Most corner delis are making more than that. It's just that they've got a very large sum of money that they're insuring, so a small margin is quite a lot that they're able to deal with. But they're not a particularly profitable group because there are constraints by the Private Health Insurance Administration Council, our regulator. The Minister always has a say in this, and in fact it clearly demonstrates that they don't want them to be too high. And of course there's competitive pressure. Every one of the funds that I represent has a metric on their board reports that is something like member complaints or something like that, and they know that when they put the premiums up too high they get a lot of complaints. The other really important thing is that every fund which I represent knows that there's a thing called portability, which means that if a person in Fund A doesn't like Fund A, they can move to Fund B at the same level of benefit with no penalty. So it's actually a very competitive industry. So there are all of those pressures on making sure that the premiums don't get up too high, but we do have to cover the 9% increase in costs over which at the moment we have no control and which we'd like to have a greater measure of constraint over.
All right, I think we'll hear more on this debate in the months ahead, but we do thank you for joining us this afternoon. Michael Armitage there, the head of the Private Healthcare Australia.